We left off getting ready to talk about cause of intervertebral disc disease. As all of us and animals included, as we get older, remember we said the inner portion of the disc, which is called the nucleus pulposus, is typically filled with a very water-like, non-viscous, jelly-like material that acts as a shock absorber, basically. But as we all get older, the discs tend to dry out. So they desiccate. And notice that's not, they don't defecate, they desiccate. Okay, so we have disc desiccation, which means they dry out as we get older. And that is named chondroid metamorphosis. So over time, they dry out and they become more brittle, more fibrous, and they lose their water content. Okay. That typically happens younger in age in some of these chondrodystrophic dogs that are prone to intervertebral disc disease, like your dachshunds, and again, your Frenchies and your bulldogs and things like that. So again, it typically has an older non-chondrodystrophoid onset, but in the chondrodystrophoid dogs, it can happen earlier on in life. So as these discs dry out, again, they become more brittle, they become less pliable, they become calcified, and all of that can lead to disc herniation. As they become more brittle, as you bend around and move around and jump down from a couch and stuff like that, then typically it can lead to intervertebral disc disease. Keep in mind that intervertebral disc disease is exceedingly rare in a cat for whatever reason. Okay, cats hardly ever get disc problems. It's extremely unusual. So it doesn't, I'm not saying it can't happen, but it's usually hardly ever does. So what do we look for? There's a couple of things that will go along with this drying out or desiccation of the discs. One thing that we can look for as animals get over is they can have mineralized discs that we can see on radiographs. And this term in situ means that it's, I guess, Latin for means in the right spot. At least that's the way I interpret it. And so we get these little areas of mineralization in the middle of the disc spaces. Here's the one here that's even kind of shaped like the disc. Okay, so these are mineralized discs that live in situ, not in stew, but in situ in the intervertebral disc spaces. Okay, so if you see these mineralized discs on radiographs, by definition, that means the animal has intervertebral disc disease. On the other hand, it doesn't mean they have a compressive lesion of the cord. So this disc here, it's mineralized, so that means it's desiccated, which means he has intervertebral disc disease, but it doesn't not necessarily mean that he has extrusion or protrusion of the disc that's putting pressure on the cord that goes through this spinal canal. Okay. Here's a normal disc space here, and here's these lateral spinous processes that you don't want to confuse. Remember, this is one of those weirdness things we talked about. You don't want to confuse this opacity for a mineralized disc. Okay, so here's an oval shaped mineralized disc in here. So he's got disc disease, but it doesn't necessarily mean that part of it is actually protruding up in here into the spinal canal, putting pressure on the cord. Okay, and you'll learn about more of this by the neurology guys, but there's two types of disc herniations, and they're named after, in this particular case, on the human side, Hansen's type 1 and Hansen's type 2. I have no idea who Hansen is, but I assume he's some neurology doctor that described these on the human side a long time ago. Okay, so in the chondrodystrophoid dogs, the dachshund type dogs, again, they get early chondroid metamorphosis and desiccation of the disc, which makes them friable, and they can lead to extrusions like we see in this particular thing. Typically, these dogs are going to present with acute clinical signs. So this is your typical dachshund, Frenchie or whatever, that jumps off the bed or jumps off the couch and lands on the ground and is now acutely paralyzed. Okay, and that's because he jumped off, he torqued his back in a weird way. This disc was prone to having problems because of this condition. And now we have blown out or herniated out part of the disc material that sits around the spinal cord in the spinal canal and immediately puts pressure on the cord, which leads to pain and paralysis. So Hansen's type 1, what you need to know, Hansen's type 1 is associated with the chondrodystrophoid type dogs, which are the dachshund type dogs, and it causes acute clinical signs. As opposed to the Hansen's type 2, which is all the other dogs, the non-chondrodystrophoid dogs. It also is caused by the drying out or desiccation of disc, but most of these dogs have slow onset, chronic, mild signs. So they might have back pain, but they may not be paralyzed. Okay. At some point in time, this may also then over time cause a herniation and extrude out too. But again, typically these type 2 dogs will have onset of clinical signs that's much milder and slower and more chronic. Okay, and not to beat a dead horse, or I guess in this case a dead dog, but we have to make sure that we have good positioning for these radiographs. So the dog has to be smartly aligned. He has to be straightly positioned where the vertebral body and the spinal cord is straightly aligned here. And to do this, sometimes we have to put little wedges or bean bags or foam wedges or towels or something underneath the dog to where we have nice straight alignment of the spine. Because otherwise, if you just threw him on the table, it's going to be all crooked. Okay. And again, they're wider here on the back end where the back is than up here where their feet. So they tend to kind of flop that way. And so sometimes you have to put some kind of positioning device or foam wedge underneath their feet to bring it up off the tabletop, which makes this be straight. If you have crooked films, you can't make a diagnosis. Okay, so what do we look for intervertebral disc disease in these dogs on plain films? Well, we look for basically a couple of things. One is we look for, assuming we have nice straightly positioned lateral views, we look for an intervertebral disc space that is more narrowed than the ones around it. So again, you can appreciate that this disc space here is more narrowed than this one, and it's more narrowed than that one. Then we look for the same thing associated with the intervertebral foramen. And again, the other name for this, kind of the lay term, is the horse head, because I guess to some people this looks like a horse head. So we look for narrowing of the intervertebral foramen compared to the ones around it. We also look for, is there increased opacity in this narrow disc space? You can imagine that if you have extrusion of disc material and it's gone up inside of here and it's sitting up in here, that will cause increased opacity because now we have disc material in the foramen that we don't have in these. Okay. Also, the dorsal articular facets can also become narrowed. So the joint between these dorsal aspects of this vertebral segment becomes more narrowed than the ones around it. So what do we look for with plain films? In general, we look for narrowing of the intervertebral disc space compared to the ones around it. There's an example of that. Okay. We look for narrowing of the intervertebral foramen and possibly increased opacity within the foramen. And we can also look for narrowing of the dorsal articular facet compared to the adjacent ones. And all that kind of makes sense. If we blew out the disc, the body's going to pull those areas together. It's going to become more narrowed, more increased opacity. This becomes narrowed and that becomes narrowed because we don't have a disc there anymore. Okay, so here's a real world example. So this is T13. This is our last set of ribs. So this is at the TL junction, which is a very common site for these dachshunds to have intervertebral disc disease. So we can see this space here looks more narrowed than here and more narrowed than here. Okay. This one's a little bit crooked. He's not positioned nicely because now we have a rib neck that sits right on top of the intervertebral foramen. We can see it here. We can see it here. We don't see it here because it's narrowed, but it's also, we don't see it because we got a rib on the top of it. So this dog is not positioned really nice and straight. So again, we look for increased opacity in the foramen. Here we can see that same opacity here. And this dog, he's another dog, is positioned straighter. So here's T13, here's L1, this is an L2, L1, 2. So narrowed disc space, narrowed foramen, and increased opacity in that foramen. Okay, this is in the cervical region. So what is this thing right in here? What is that? What are we going to call that? What's the doctorly word for that right there between C2 and C3? That's a mineralized disc in situ. Okay. And if you look real closely on the VD view, you can also see there's this mineralized disc in situ between C2 and C3. So you can see it on both views, which makes your confidence level high. But if you look real closely, it looks like there may be some of it that's extruding up in here into the spinal canal itself. Can't really see that on this view. And this is kind of iffy. So we don't know for sure, but it's, you kind of get a hint of it. Here's another dog here. We can see here's narrowed facets. Look at these narrowed facets compared to the ones around it. This one's pretty nice and well defined. This one's nice and wide. This one's really narrowed. Plus he's got a narrowed disc space here. He's got mineralized disc material here and here, and he doesn't here, but this one may have already protruded out. Okay, here's another dog. This is a chronic, probably a chronic intervertebral disc disease dog here. And why do we say that? He's got it in a couple sites. So this is L7, there's the sacrum, L7, 6, 5, L4, 5, and it's super narrowed compared to these. And he's also got narrowing up in here. So that would be 4, 3, L2, 3. He's got spondylosis starting to form here and here, which we don't care about. It's incidental. But we have severe narrowing of the disc space here at L2-3 and L4-5, okay? See how the adjacent end plates here are more white? They're really opaque compared to the other ones. That's called bony sclerosis, and you get that with chronic disease, okay? So the sclerosis, the increased opacity of the adjacent end plates tells me this is probably chronic and been there a while. Do you see the actual disc material coming up into the spinal canal at either of these sites? No, not definitively. And that's why a definitive diagnosis of the site and side, right to left, of disc material protrusion or extrusion will require MRI or this other procedure called a myelogram. We can see hints of it by narrow disc spaces in foramen and facets, but we most of the time can't see the disc material itself or the amount of compression of the cord. So a myelogram is a study to help specify exactly at which site, if there's more than one site or only one site, that you may have what's called an extradural compressive lesion caused by disc material that's herniated out. And it's a special procedure where we used to do these all the time. You inject a specific kind of iodinated contrast material into the subarachnoid space, which is that covering around the spinal cord. So you end up sticking a needle in the dog's back. And typically you would inject this stuff at about the region of L5-6, and you inject it into the subarachnoid space, and it runs up all the way through the entire spinal cord and allows you to see if there's pressure on the cord at any particular site. Very rarely will people still do these. There's some side effects. They're usually not horrible because the contrast we use to do these now is pretty safe. But some of these dogs will have seizures once they start to wake up from anesthesia, which you can control with Valium, and then they go away. But there are some side effects like that that can happen with myelography. So here's an example of a dog. This is a normal dog, and you can see here's our needle. So it's a spinal needle. It goes right through the facet, and we stick it right down in here to where it ends up in the subarachnoid space. So how would we know if we're in the subarachnoid space? Well, we said the subarachnoid space is full of what? The subarachnoid space contains cerebral spinal fluid. So if we are in the right spot, when we stick this in, we'll get clear cerebral spinal fluid out the needle, out the hub, which you can collect and analyze. But if we get it, we know we're in the right spot. And so once we see we're in the right spot, then we can inject this contrast material into the subarachnoid space, which will outline the cord. So it's this white stuff around the cord. This gray area right in here is the spinal cord itself being outlined all the way around it by contrast material in the subarachnoid space. And you can imagine that if you have a disc protrusion, it's going to cause an indentation or thinning or dorsal deviation of this part of the cord if you had a problem. Okay. Again, hardly anybody does myelograms anymore. Let's see if I have it here. Yeah, here's an example. This is a myelogram at C2, 3. So here's C2, here's C3. So again, we have this contrast material around the cord. See how here it's severely dorsally deviated? And that's because this disc material here has herniated out and is putting severe pressure on this part of the spinal cord. So that's how a myelogram can help you. And again, people used to do, up until probably 5-10 years ago, people did myelograms all the time in animals and in people. The thing that has replaced this is MRI. Okay, MRI, you can do this, you can diagnose the same thing, and it's non-invasive, and there's very little risk to it, and it gives you much more specifics about it. But myelography is still done by some places, and there's nothing wrong with it. It can definitely show a lesion. Once you see a protrusion or extrusion of disc material that's causing this indentation and thinning of the cord, then the surgeons will go in and take this disc material out, remove it, which takes pressure off the cord. So now the dog doesn't have neurologic signs anymore and is pain-free. Okay, that's what neurologists will go do. So the myelogram or MRI, why would you do one of those? Typically, you're going to look for a compressive lesion like this is. So an extradural, outside of the dura, compressive lesion, okay? And sometimes there's going to be more than one site. Some of these dogs will have an old site. So they may have had a disc extrusion 2 years ago and they got fixed. And now he's got another one at another site. And so sometimes they'll have more than one sites, more than one episode. Some of these dogs, they'll come in on their neuro exam and they have a condition called hematomyelia, which you don't need to worry about right now. But basically that means the cord is so damaged by the pressure on the cord that the cord is so damaged, the dogs have no deep pain. If you squeeze their toes, they can't even feel it. And usually that prognosis, even if you went and took the disc material out around the cord, because the cord is already so damaged, the prognosis is poor. Okay, so that's what we would look for with, and why we would do an MRI or a myelogram. So the bottom line for you, the plain films give you a hint of where the problem may be, but it doesn't typically see the actual compressive lesion, or it can't judge the amount of compression of the cord. And also, it doesn't tell you if the dog has had a chronic disc disease, because that space is going to stay narrowed on plain films, or if the reason for his paralysis now is due to that old lesion or a new lesion somewhere else. And so that's why we end up having to MR these dogs nowadays or do a myelogram. And again, MR is the way most people do it now. Okay, so this is called an extradural compressive lesion. There's several things that can cause it. Most commonly, it's going to be caused by extruded disc material that came out of that site, and now it's putting pressure on the cord. But there's other things that can cause it too. This is the most common one. Sometimes you can get neoplasia that can occur and put pressure on the cord that lives outside or extradural in its location. Okay, a meningioma or lymphoma would be good bets there. Sometimes dogs that have been hit by a car or kicked or undergone trauma, they can get just a big blood clot in the outside of the cord that puts pressure on the cord, and some other weird things too. This one we'll talk about, we talk about lumbosacral disease. Okay, vertebral body neoplasia. So cancers that can happen associated with the vertebral bodies themselves, or the bony part around the spinal cord. Okay, you can get both primary and metastatic tumors that can affect the vertebral column. The primary tumors typically will arise from the vertebral bodies, or possibly from the lamina, the horizontal portion around the cord, or the dorsal aspect of the vertebral body. Primary bone tumors are typically going to be located only in one site. It's kind of like primary lung neoplasia, lung tumors. Typically you have one big mass, and a lot of times it's in the right caudal lung lobe. Okay, same way with vertebral body neoplasia. A primary cancer of the vertebral bodies typically happens in one site. Okay, so what do we look for? The majority of these primary bone tumors or neoplasms are lytic, so they eat bone away, they destroy the bone. And the most common one, there's several that can happen, but the most common primary bone tumor of dogs is an osteosarcoma. These are nasty, aggressive, very painful tumors that can metastasize to the lung pretty readily. So what do you look for? Is you look for lytic changes in the bone that we'll talk about. The exception to this rule with primary tumors is this weird thing here called multiple cartilaginous exostosis, abbreviated as MCE. This is a weird thing, and the cool thing about this one is it causes these areas of bony lysis and production of usually multiple areas in the spine or the ribs. And the owners will be, and it happens only in young dogs, okay, or cats, and they'll be petting their dog, and over time they develop, they'll be petting them, and they'll say, oh my God, this big mass, I feel this big mass in the region of his spine. and you'll x-ray them and you'll see this kind of big multilobular lytic and cauliflower looking thing. And as this gets bigger and bigger and bigger, it can also get bigger this way and put pressure on the spinal cord and cause neurologic signs. The weird thing about multiple cartilaginous exostosis is when this dog stops growing, this will stop growing. Okay. And so once he reaches skeletal maturity, so a year of age, if this isn't already putting pressure on the cord, then it won't, because it stops growing. It doesn't go away, but it won't get any bigger. Okay. If it is putting pressure on the spinal cord and causing neurologic signs, then you'll have to, the surgeons can go in and remove part of it to where it does not putting pressure on the cord anymore. So that's the weird exception to primary bone tumors. The rest of the primary bone tumors are going to be lytic, and I'll show you some examples of those. Other types of bone tumors that can affect the vertebral column would be metastatic tumors. So these are tumors that have metastasized to the spinal column from a primary prostatic carcinoma or transitional carcinoma or a mammary carcinoma that has now moved and metastasized to parts of the spinal column. Okay, so the hard part about a lot of these primary vertebral body tumors is you're looking for something that's not there. It's easier to pick up on a radiograph something that is big and bony production and this big, like that MCE lesion, that like this big thing here. It's easy to look for something that is big and abnormal like that. It's harder to look for something that is subtle and just not there. Okay, so typically with these vertebral body tumors, it causes lysis. So you look for part of the vertebral body or the lamina or the process that's just not there, and it can be easily missed. Typically, these are going to be in older animals. Okay, so again, if you look, everything looks pretty good, nice straight view here, but if you look real subtly, there's this lucent lytic lesion of something that's aggressive, that's eating the bone away in this particular area. If you look at it here, you should see a nice crisp line along the dorsal aspect of this vertebral body. Here you see a nice crisp line, and here you don't. It's kind of gone. Back here you do, but this part looks like somebody took a big bite out of it. Okay. If you look at this same area, this is L6, which is L6 here. On the VD view, look at this lateral spinous process here. That's nice, well-defined. Same thing here, same thing here, same thing here, but not here. Over here corresponds with this lytic lesion here. It looks like, again, somebody took a big bite out of that bone and it's not there anymore. So that would be a typical appearance of a primary bone tumor that occurs in this vertebral body, in this particular case on the right side in L6. And these dogs, again, they're going to show severe pain due to lytic lesions. Most of these dogs are going to be older. As this gets bigger and bigger and bigger, it's going to grow in and put pressure on the spinal cord in the spinal canal and cause neurologic signs. Here's another animal here. Okay, so here, this dog's got mineralized disc material here, but that's probably not his big problem. If you go back here, again, he's got this focal area of lysis of this vertebral body here. And again, as that gets bigger and bigger, right above it is the spinal cord, and it's going to probably put pressure on the spinal cord in that area. So that's a typical, appearance of a aggressive lytic lesion involving a vertebral body. And sometimes it can be very hard to spot because, again, you're looking for subtle lytic changes in the vertebral body itself. Another weird one that's super aggressive, that's a tumor, is called multiple myeloma. And this one occurs not just in one vertebral body, but basically every one of them. And you look for all of these purely lytic punched out areas all over in all of the vertebral bodies and the dorsal spinous processes everywhere that you look. Okay, this can occur mostly in the vertebral bodies and the column and the dorsal spinous processes, but sometimes you'll even get lesions that are in the femur or the humerus or the ribs or something like that. And multiple myeloma is a aggressive blood-borne tumor that causes severe bony lysis of the spine. So the way I look at this is it looks like somebody got a hole puncher, or in this case, a bone puncher, right? And started punching out holes all over all of the skeletal structures. And it's so aggressive that it causes pure bony lysis. There's no bony production. It's so aggressive, the body doesn't even have time to try to fight it. It just starts causing bony lysis all over your skeleton. Extremely painful, horrible prognosis for these dogs. Okay, multiple myeloma. Here's an example. This is another myelogram here. This is an example of a compressive lesion caused most likely by a tumor here that's causing compression of the dorsal aspect of the cord. Okay. That would be the same thing as if it was a disc, except the discs don't live dorsal to the cord. They only live ventral to the cord. And so it's probably not a disc. Here on CT, this is a CT myelogram, and MRI will show you the same thing. But you can see here, there's compression here. But if you CT it, it's much more obvious. So here's different slices through this same area, cut in this direction here. And if you look here, this is the spinal cord here, and it's surrounded by this white contrast material from a myelogram. Here's another slice a little bit further down caudally, and here's another slice here. But if you look here, there's this large compressive lesion that's causing deformation or flattening of the cord itself, and the cord is squished. The cord should be nice and perfectly round and fill up the majority of the space, but now we have a tumor that's invading into the spinal canal and causing compression and squishing of the cord. And so that's what's going to cause the pain and the neurologic signs that this dog might have. Okay, so we've kind of talked a little bit about intervertebral disc disease in these dogs. So let's move on. The next one we're going to talk about is called Wobbler's disease. Hang on, I got to respond to a text with my daughter. Hang on just a second. Okay, so sorry about that. How many of you heard of Wobbler's disease? Yep. Okay. Wobbler's disease is, the other name for it is called cervical vertebral instability. There's a couple other names now. A lot of these disease conditions don't change, but the pathologists have to change the names because they get bored of what they do. So they just like, let's rename it. And so the other name that you'll see now is called cervical vertebral spondylomyelopathy. Hang on. This reminds me of a story, which I'll tell you real fast. One time I was in a meeting. I was in like a board meeting. I'm on the board at Western Vet Conference, right? This wasn't for this, but I was on another board meeting. I'm sitting in this like all day long meeting. It's pretty intense and all this. And I keep getting, these texts from my wife, and I'm not answering it, because I'm busy, and she knows I'm in this meeting, but of course that doesn't matter. And so then, I get a phone call from her, and it's like, oh shit, some emergency, something's happening that, okay, I better take this phone call. And so I walk out of the meeting, and I'm standing out in the hallway outside the doors of this meeting. And I'm like, okay, what's the deal? What's wrong? Who's sick? Who had an accident or whatever? And all I hear was, hey, do you know, I think we're out of mayonnaise. She goes, in the jar in the fridge, the mayonnaise, it looks like it's empty. Do you know if we have any more mayonnaise? And I'm like, I don't know if we have any more mayonnaise. Why don't you go look in the cupboard and see if there's another jar of mayonnaise in the cupboard? Oh, okay. So anyway, we have to deal with things like that. So that's what reminded me. My daughter's having a panic attack because she has my wife's car, because hers is in the shop, and she can't figure out how to open the gas cap. So basically, and then she's texting me again. So now she's wondering about, now it's going to be, what about mayonnaise? Okay. So she finally got it. So here, she finally got it. She says, I opened the gas cap. Woo, I'll be able to sleep good now. Okay. So let's continue on with our selection about cervical vertebral instability, otherwise known as Wobbler's disease, otherwise known as cervical vertebral spondylomyelopathy. This is a complex syndrome caused by lots of things that all lead and manifest into these dogs having cervical pain, and they're unstable and they're ataxic with wide base stances, and they don't like to move their neck around because it hurts. Okay. This is a specific condition that happens in the most common one is going to happen in Dobermans, but it can also happen in Great Danes and any other dog, basically, that has a big, long neck. Okay, I don't know if it happens to giraffes or not, but it seems like it should. Okay, so if they have a big, long neck, they're going to be more predisposed to cervical vertebral spondylomyelopathy or Wobbler's disease. Okay, so Great Danes, Dobermans, typically they're middle-aged dogs, and they come in and they're ataxic, which means they can't control exactly where their feet are. They have a wide base stance because they're kind of dizzy and they don't know what the hell's going on. Hemi to tetraparesis, so it may affect just the front limbs, or it may affect the rear limbs too. This wide base stance because they're just trying to maintain and balance, right? You can get plain films, but typically you can't diagnose this definitively on plain films, and you typically have to go to either a myelogram or, again, MRI is the way to go with these dogs. The most common sites are going to be in the mid-caudal cervical spine that these dogs will have affected. So what leads to this? Basically, the vertebral bodies are okay, but the ligaments that connect and stabilize this area in the cervical spine, the ligaments are damaged, or they're not very strong, they're kind of weak, and it leads to one of the vertebral bodies being able to tip up dorsally and cause malalignment of the cord. Okay, if you drew a line that connects this line here, it's going to connect to here, but it doesn't connect here. This part of that vertebral body is tipped up dorsally, which obviously then will put pressure on the spinal cord. Okay, that's what happens with this Wobbler's disease or cervical spondylomyelopathy. Okay, there it is right there. Again, sometimes on plain films you can get a hint of this, but again, to see the actual compression of the cord is when you have to MRI these dogs or do a myelogram. So again, here's just, it can cause wedging of this part of the cord. This part of this part of the vertebral body can be kind of planed off and not nice and square like these are, okay? And it can cause narrowing of the spinal canal and pressure on the cord. So again, if you look here, this is a lateral radiograph, nice, straightly positioned. Again, this part of this vertebral body may be tipped up a little bit dorsally, causing narrowing of this part of the spinal canal. And same thing here, maybe a little bit narrow, but nothing truly definitive that I can see. Okay, again, this part's wider than this part because this is planed off. So again, how do we diagnose these? This animal here, we did a myelogram. You can see this little area here that has contrast in it, and this, if we gently flex their neck down like this part of that vertebral body is tipped up, and again is putting pressure and narrowing, causing narrowing of the cord itself. Here's another example. Again, we can see this extradural compressive lesion caused by this tipping of the vertebral body putting pressure on the cord. So somebody said that radiographic findings you can see on plain films in 80% of these cases, but in my mind, it's very subtle changes. And if you suspect a dog that comes in, he's ataxic and he's a Great Dane or a Doberman, probably the best thing to do is not waste the client's money to take plain films, because you need to probably refer them for an MRI or refer them to a neurologist who are going to be able to make a more complete diagnosis with MRI and then do something about it. Some of these dogs have static lesions, which means no matter how they position their head and neck, they're going to be paralyzed and they're going to be ataxic, okay, with a lot of neck pain. Some of the dogs have learned that if they keep their neck down like this, they're less painful and they feel better. And so a lot of these dogs will present and they're constantly having their neck down because they've learned if I raise my head up like that, everything gets worse. It becomes more painful and I get all these neurologic signs. So they learn to keep their neck down, okay? So again, we can have lesions that are static, no matter if we flex the neck, they're neutral, or they extend the neck, they have a compressive lesion that's causing pressure or indentation of the cord. On the other hand, here's an example of that. So no matter where we position his neck, we have this thinning and compression of the cord. Some of the dogs are dynamic lesions. So in the dynamic lesions, if we flex their neck, you can see there's no compressive lesion. Everything looks good. The cord's fine. But as soon as we raise their neck up, then we can get compression of the cord. And that's why these dogs that have these dynamic lesions will keep their neck down. So how do you fix these dogs? The surgeons or the neurologists can go in and they put screws in this vertebral body and screws in this vertebral body, and they basically create spondylosis with a bunch of cement, which is called methyl methacrylate cement. And they try to keep this narrow disc space in alignment. and that will take the pressure off the cord when they try to fix these dogs. A lot of times it works okay. Sometimes it doesn't work that great, but there's not much else you can do. Okay, so here's another example of compression of the cord due to a dog with Wobbler's disease. So I think you, as the general practitioner, if you have a taxic Doberman that comes in and you suspect he might have Wobbler's disease, again, the first thing that you should probably do is find out where your nearest referral center is and send it off to a neurologist so it can get MRI'd and then hopefully fixed. Okay, another one that we're going to talk about is called lumbosacral instability. Lumbosacral instability is also called cauda equina syndrome. Let's go look at a picture of what this is. Okay, so again, now we're back in the L7-S1 area. And if you look, this is the L7 vertebral body. Here's the sacrum. And there's a disc that normally sits between L7 and S1. Okay, the anatomy dorsal to that, the spinal cord in a dog typically stops, the tip end of the spinal cord is called the conus medullaris, and it typically stops around L5 or L5-6. And if you remember from anatomy, that once the spinal cord tip stops, it sends out these little nerve roots that go out through the rest of the spinal canal, and they pass through and over L6, L7, and L7-S1 and go out into the tail. Okay, and remember, those nerve roots are called the cauda equina, because somebody a long time ago thought when they dissected down and saw these individual little nerve roots coming out in here, it looked like a horse's tail. So they called it a cauda equina. Okay, so those nerve roots pass right over L7-S1. Now, what neurologic function, and you'll learn about this if you haven't already, what does these nerve roots control? Well, they control the movement of the tail, pain sensation of the tail, but also a lot of these nerve roots will also control the ability of the anal sphincter to do its thing, okay, to, you know, stop uncontrollable feces leakage, which nobody likes that, right? And then it will also, a lot of these nerve roots will also control the ability, the willingness to have controlled urination. And so if you damage the nerve roots of the cauda equina over the L7-S1 area, a lot of these dogs will be fecally incontinent and urinary incontinent, which makes for a tough time to have a pet around your house. Okay, so that's why it's so important in here. And so dogs with lumbosacral instability, they can get either a disc protrusion or extrusion like this up into the spinal canal, which puts pressure on these nerve roots of the cauda equina, or there's a ligament that lives right over this area, and that ligament can become too thick and again put pressure on the nerve roots of the cauda equina, which leads to fecal incontinence and urinary incontinence and severe pain and problems with the tail. Okay, so that's called lumbosacral instability. And again, the only way to diagnose this, a lot of times on plain films, you may see narrowing of the intervertebral disc space like this. Okay, sometimes you'll see this, what's called a step lesion, but the only way to actually diagnose if there's compression of the nerve roots of that run through this area, the nerve roots of the cauda equina, is to MRI it. Again, MRI is the neurologist's best friends because that will show specifically, yes, there's compression and how severe it is. Plain films, again, can give you a hint that there is an abnormality here because this disc space is narrowed. And sometimes they'll get, again, this step lesion. Again, if I had a line and I made my line go straight through here along the dorsal aspect of these vertebral bodies, so it goes from here to here to here, and then it jumps down, there's a step lesion to go to this part of the sacrum. Okay, that means this joint space is probably unstable, which can lead to either extrusion of the disc material or hypertrophy of that ligament. Okay, the other thing to keep in mind here, this dog has a transitional vertebrae. Remember, we already talked about that. This is that confused vertebrae. It doesn't know if it wants to be a sacrum or it wants to be a lumbar vertebrae, so it's kind of half and half. So bottom line is these dogs that have transitional vertebrae involving the lumbosacral region are going to be predisposed to lumbosacral stenosis. Okay, The transitional vertebrae in itself doesn't really cause a problem, but over time, these dogs will be predisposed to have this problem as they get older. Okay. Okay, so look at this step lesion here. Here's L6, here's L7. Again, if I went through here and drew a line along the ventral aspect of the spinal canal, it goes from here and then it goes, whoa, way down here and connects here. So that's a huge ventral step lesion. See how this part of the sacrum looks like it's dropped out ventrally, okay? And so that is gonna, most likely, he's gonna have an involvement and compression of the nerve roots of the cauda equina, because here they're going right down the spinal canal in the middle of it, but now they have to come down here and go through the middle of it here. And there's this huge step lesion. So most likely the nerve roots are going to be affected. But the only way to know that for sure would be to MR them. Now, what is this bony buildup between L7 and S1 called? What is this called? What is this called here? Very good. That's called spondylosis deformans, right? And so again, spondylosis is really common. Spondylosis in and upon itself is incidental. We don't care about it. Okay. You've got really bad spondylosis here. That's not his problem. It's not the spondylosis. It's this problem here, this big step lesion and probably compressing the nerve roots of cauda equina. There's this big step lesion. Okay, so here's a sagittal view of a dog that got MRI'd. And so here's our disc space here, here's our disc space here, here's our disc space here. But now we have this extrusion of disc material that's putting pressure. This black line here is the nerve roots of the cauda equina, and you can see it's compressing the nerve roots of the cauda equina at L7S1. And the surgeons then can go in and try to take this disc material out, which will take the pressure off the nerve roots of the cauda equina and make this dog a lot better. Okay, lastly, we're going to talk about this really quickly. This is called a condition called hyperparathyroidism. And you're wondering, why in the hell are we talking about an endocrine disease if we're talking about neurologic stuff? And that's because it affects typically the skull first in a lot of these dogs. So primary hyperparathyroidism is due to an adenoma, a functional adenoma or benign growth of the parathyroid gland that causes hypercalcemia in these dogs, which in turn will cause bony lysis and diffuse osteopenia. So it causes the bone to lose its mineral content and calcium content, okay? Secondary hyperparathyroidism can happen in animals with chronic renal failure, and it can also happen in exotics that are not on a very good diet. So that would be a nutritional secondary hyperparathyroidism. So again, why are we talking about this? Let's just go show you. Here's an example here of the dog's skull. This is a really poor example, but basically it's trying to show you that what happens is the mandible, the cortex of the mandible starts to dissolve away. It starts to become very thin and eggshell-like, and then it will start to also affect the maxillary region. And it looks like the teeth are super opaque because there's no bone around them. And if it's really bad, it looks like the teeth are floating in space. It looks like there's no bone around to hold the teeth in, which is true. Okay. Here's a dog that has hyperparathyroidism. So again, look at the mandible. It's paper thin, super thin, because the body is absorbing or resorbing all of the bone and mineral content from this area of the mandible. It's starting to become very thin up here in the maxillary region here. And comparatively so, the teeth are super opaque, and it kind of looks like there's very little bone around them. And again, this is either primary, because by a parathyroid adenoma that's causing resorption of bone, or it can be renal or nutritional secondary hyperparathyroidism that will do the same thing. And so if you have a dog that comes in and he's got, mouth pain or whatever, and you x-ray him and he's got little to no bone in the mandibles or in the maxillary region, it looks like his teeth are floating, you start to worry about one of these hyperparathyroid conditions. Okay, so you would run a calcium and phosphorus level and see what the ratio of the calcium phosphorus levels are. Typically, they're going to be super hypercalcemic, and then you have to figure out why. Is it due to chronic renal disease? Is it due to nutritional abnormalities? Or does he have a benign growth that's causing too much parathyroid hormone to be secreted? Okay, again, the relative opaque appearance of the teeth compared to this lytic diffuse. Now, why do you get the lysis starting in the skull region and the mandible? Again, that falls into the realm of a noble question. I don't know. Okay, so that's again, you would ask when you get to heaven to get answers for these questions. Okay, it can also cause, again, bone loss elsewhere. So again, if you look at the vertebral bodies, even in the lumbar area, it's kind of eggshell-like mineralization around them, not very well defined. It's very thin, and that's because he's resorbing bone from his entire skeleton, but typically it will start up in the mandible and in the maxillary areas. And with that, we have finished the exciting world of neuroradiology. Okay, there's a lot to go. So bottom line is